Welcome to our Galway Clinic Ortho-Info Patient Information Series, being delivered to you by the Galway Clinic in partnership with Professor Cathal Moran. Cathal is a well-known consultant orthopaedic surgeon, Professor of Orthopaedic and Sports Medicine, and a specialist in the management of pain and injury of the shoulder and knee. Cathal, delighted to have you here with us today, and thank you for joining us on this discussion.
Well, I'm delighted to be here, Claire, and it's great to be together again and also to help our patients however we can.
Today we're going to discuss knee pain. Can you tell me what causes knee pain?
Well, Claire, I suppose there are quite a number of causes of knee pain. I suppose we need to think both outside of the knee itself and within the knee. Outside of the knee, we think about factors such as back pain, we think about hip pain. They all can be referred down towards the knee by the nerves and so on. But if we actually think about the knee itself, most conditions of the knee are wear and tear conditions that happen over a lifetime. And wear and tear particularly happens to this area here, the cartilage, the lining cartilage of the knee, are of these little structures in here called the menisci or shock absorbers of the knee. Sometimes we can get maltracking ideas where the knee cap doesn't quite track centrally down through the groove that's there for it. People over a lifetime obviously have a lot of wear and tear. It might go back to old injuries, it might go back to new injuries and so on, and often it's just life's wear and tear. Various tissues, the tendons of the knee can flare up. So really, I suppose there's quite a myriad of reasons, and that's why we like to have a chat with patients about what the background might have been, whether they've had any injury or whether they feel it's just something that's come on gradually over time.
Many patients don't remember injuring their knee, but they still have pain. Why is this, or what might it be?
Well, I suppose, again, going back to that, any of those structures can become gradually worn out over time, but there are, I suppose, various symptoms that we speak to patients about. And there are a number of red flags or perhaps reasons that you might look to go and see your doctor. If, for example, you've had a recent injury and you notice severe swelling, pain or weakness, or if you cannot weight bear on your knee, or if, for example, you've had a twisting injury and you feel it buckle. Other ideas or problems are where little parts of the knee, such as the cartilage or the menisci, could break off and become loose in the knee. One could feel a little grinding or popping in the knee and so on. They're the reasons, and I suppose it's the symptoms and signs that we look for to help try and define what the cause might be and how we might direct treatment.
What can patients do to help their pain?
Well, as I say, if we think about it, first of all, the majority of problems around the knee are wear and tear conditions. They're not due to acute injury. So in that scenario, generally reassuring patients in the first instance that it can be quite common, and often it's not necessary to rush off to the doctor straight away. Typically, one can rest the knee. We talk about activity modification for a few days. Elevating it in the evening is a useful thing. But the other important thing is that once the first couple of days go by, we talk about exercise and movement being important. Typically, to help them in the early stage, some over-the-counter medications such as a paracetamol or a Nurofen or something like that can be helpful. But typically, once the first most painful episode has gone by, we encourage movement.
Will exercise cause a further damage? If not, what exercises should they do?
I suppose patients do have that fear, and it's one of the most common reasons I think patients do come forward for consultation. They have this fear of maybe making matter worse. Most people can put up with a little irritation and know it will gradually wear off over time, but I think the important message to get out there for our patients is that movement and exercise is important. It's an important way of the body healing, and it's very rare that you could do significantly more damage through gentle exercise. I suppose typically the most common exercises people undertake are walking. Now, walking done intensely can be an impact activity, but generally light walking would be encouraged. Then if people, I suppose, are finding walking difficult, the use of a bike would typically be a non-impact or much more gentle activity. Then other things like swimming, using a stepper, cross-trainer and things like that are important. We have exercises made out on our own practice website, but they're also available generally. But I suppose typically if people are struggling in those early stages, we might encourage them to see a physiotherapist, a physical therapist, or their own personal trainer to give them some guidance. Most people, once they have some initial guidance, can work away on their own and see how matters go.
Should a patient organise a scan?
I think it has become much more popular that patients do like to have MRI scans, and certainly many, I think, GPs and physiotherapists probably do reach for them early. They do make up sometimes an important aspect of our own assessment process as well, but it's not typically the first thing we would go for. Often I would like to consult with a patient, maybe I'd take their history, find out the story behind it, find out about what they've done so far, and in that context we might go for an MRI scan. Before ever having an MRI scan, we typically use x-rays. X-rays shows really how the bones are aligned, what they look like, whether they're in good health and so on. And that typically is more important than an MRI scan in the early stages. I mean, as life goes on, everybody's MRI scan is going to show some wear and tear of the cartilage, little meniscus tears and so on. And MRIs, if they're taken out of context, can alarm patients rather than reassure them. We typically use the scan to show that there's mild wear and tear and reassure patients rather than the other way around.
How would a patient know if they need surgery?
Well, again, it goes back to that idea of not being fixated on just the MRI scan or showing a little tear in the cartilage or the meniscus. But really, when I meet with a patient, one of the key things that we like to discuss really is what the issue is for the patient, how that actual finding on the MRI scan or the symptom they have affect their life. Often we will try and do the most conservative approach first, typically take them through exercise, maybe use gels and so on to try and help them. It's really only when those processes have failed that we might opt for a surgical procedure in most cases. I suppose for me it's quite simple how we help patients decide around surgery. I suppose first of all, whether their story ties in with their examination and ties in with their imaging, their MRI and so on if it's needed, or X-ray. Secondly, I suppose the key thing is whether or not they've tried what we would regard as the least invasive but recognised treatments, be it exercise, be it physiotherapy, anti-inflammatories and so on. And then I suppose if the pros and cons of surgery weigh up for the patient, if I can explain to them that there is a procedure that may be of benefit to them and that they feel at that stage they've exhausted all the other reasonable treatments, and at that stage we might move to something. Typically we start off with the most minimally invasive surgery possible, keyhole surgery, arthroscopy and so on, but we may move up to more invasive surgery if it's appropriate for them in any case.
And when should a patient come to see you, and what might you advise them?
I suppose we always welcome patients in to see us, and that's what we're there for, I suppose, to try and help patients diagnose what their problems are, but also help reassure them that in many cases their condition can be treated without a surgical procedure. Thankfully nowadays going to see a surgeon doesn't classically just mean that you'll end up having surgery, but it involves being guided through their process. So I suppose many patients are happy in the early stages, chatting to their physiotherapist or to their GP and so on about what the early treatments are. But at any stage, if they themselves feel they would like to come and see us, or if the GP or physiotherapist is concerned, we're delighted to help at any stage.
Perfect, Cathal. Thank you so much for answering all our questions today.
Thanks so much, Claire. Delighted to be with you.
Thank you. Today's Ortho-Info patient information series has been brought to you by the Galway Clinic in partnership with Professor Cathal Moran. For a consultation with Cathal and treatment at the Galway Clinic, please see our contact details shown here.